I'm going to ask you guys to do me a favor. Anytime you hear a politician use the word healthcare, I want it to trigger something in your mind. I want you to recognize that they're not talking about healthcare. They're talking about health insurance. If you take one thing away from any of these healthcare talks that you've graciously attended, and thank you again for being here, coverage is not care. That is incredibly important. The financing vehicle is not the same as the interaction and the care that you get from the medical professional. True insurance is a financing mechanism. We talked about that yesterday. It's for catastrophic care. Healthcare can be affordable today, as we've seen in this video. DeSoto Hospital, the group that contributed to fixing that hospital did was what everybody told them that they couldn't. They went into the fourth poorest county in the state of Florida, and they not only got a hospital that was on its way to shuttering its doors to be stable, they're now thriving and growing. Where did we go wrong? I honestly wish that we could have that conversation, but that could take up an hour and a half all by itself. For that, I would encourage you to read our important research. It's outside or on our website. It's entitled A Brief History of Government Intervention in the U.S. Healthcare System. Although brief, it's still a lengthy document. But you'll learn quite a bit, and you'll understand why we have many of the problems we have today. They were manufactured by decisions made by the federal government. As important as history is for us to learn, today we focus on a vision for the future. Today we focus on what is possible. And with that, I want to introduce this panel of wonderful people who are endeavoring to change healthcare, make it more affordable and accessible and of good quality for the people of Texas and of our nation. This handsome devil to my left that was in the video, Mr. Carl Schuessler. He is the managing principal of Mitigate Partners and Benefit Strategies, LLC. More than 30 years of experience in benefits consulting and financial services. Founding member of Health Rosetta. He's a chartered certified advisor, which call him a broker at your own risk. He doesn't like that. He's an accomplished speaker and author who's engaged in the pursuit of an employer-built healthcare model. James Lagarde, CEO of Sedera Inc., over 15 years of healthcare experience and over 20 years of operational and information technology experience. His daily mission is to empower individuals to form better collaborative partnerships with their healthcare providers and to radically change the way we pay for healthcare. He serves on the Goodwill Central Texas Board of Directors and Executive Committee and is an active board member of C12 and the CARIS Group. Last but certainly not least, Senator Lois Kolkhorst. Thank you for being here, Senator. Elected in 2000 for the Texas House, and in 2014, after 7 terms in the Texas House, was elected to the Texas Senate. Chair of the Senate Committee on Health and Human Services, also serves on Senate Finance Committee, Senate Committee on Water and Rural Affairs, and Texas Agricultural Policy Board, the State Water Implementation Fund for Texas Advisory Committee, and the Texas Windstorm Insurance Oversight Board. She was named Legislature of the Year by the Texas Association of College Teachers and a Friend of Education Award from the Sam Houston State University. She's also received accolades from the Texas Medical Association and the Texas Hospital Association and many others. A graduate of TCU and a former collegiate golfer. Thank you all very much for joining us. I'd like to start with you, Carl. Tell us a little bit about what we just saw.
All right, well, first, I want to thank you and the Texas Public Policy Foundation for putting this great event on and having us here and all the great work you're doing, as I saw all day yesterday and outside. It's a great honor to be with you. We've connected before on LinkedIn, but we never met formally, and Senator Kolkhorst, it's an honor to be here with you as well. Guys, this is absolutely fixable. Healthcare can be fixed. It just, as we like to say, it takes a courageous employer. And Vince Sika, the CEO, Lois Hilton, the director of HR, and Dan Hogan, the CFO, and many others in that hospital really deserve all the credit here. They were the ones that listened to my partner, Barry Murphy, and I, and they had a vision for what they called a community health plan. And we helped them build their plan from the ground up. Today, many of these employers across this country have what we call insurer-built health care, meaning you may be a self-funded insurance plan, and you tell me that you built it yourself and you do your plan the way you want, you design your deductibles. But make no mistake about it, if you're buying it from the cartel, and that's the BUCAs, Blue Cross, United, Cigna, and Humana, make no mistake about it, it is insurer-built health care, and it is not going to reduce your costs, because that goes absolutely the inverse opposite of what their incentives are. So just know that, and that's what controls most of American businesses, is I call it the cartel, and David said it was okay to say that. But anyway, we did what we call employer-built health care, or community-built health care, Arcadia-built health care. We sat with them in October of 18 for 5 hours. I'm sure that Vince, Lois, and Dan will never forget that, because to listen to me for 5 hours, you can imagine how painful that is. But Dave, that was supposed to be funny. Y'all not going to laugh today? Rough room.
We're already feeling it 30 seconds in.
And but anyway, we sat there and built their plans brick by brick and picked the best bricks we could find. You can't save 54% by not doing some things different. One of the most critical building blocks we used was direct primary care. Is everybody familiar with that? Heard of it? There's a great direct primary care group here in the room, Direct Med, right here in Austin. Near Patel and so forth, and yourself included. So Dr. Lee Gross was really a big part of this as he brought us to the hospital. Dr. Lee Gross is known nationally. He's in D.C., I think, every other month. He's always helping write policies, been huge in the executive order in July.
Why don't you just a quick explanation of what direct primary care is?
Okay. Direct primary care, folks, is you have a contract with your doctor. There is no middle people. There's no insurance company. You have a direct contract with Dr. Balat, and you pay a subscription fee like you would pay a Netflix subscription fee. You pay a subscription fee. It could be $65 per adult, $25 for the first kid, $10 for each kid thereafter. And they take care of you. Some of them dispense medications. They treat. I tell you the biggest thing that I thought, David, that was so substantial, even the hospital was surprised. I'm 52. I know I look like I'm 35, but that wasn't supposed to be funny. But anyway, I need a colonoscopy. My wife will kill me for saying this publicly. I haven't had my colonoscopy. Part of Obamacare was, if you're over 50, you can get a preventive colonoscopy done for free. I know I need to do it. I'm going to do it. But that's right. But you go to Dr. Gross and Dr. Crouch's office, and you need a colonoscopy, you ain't walking out of there without it being scheduled on the spot. You need an MRI, you need an extra blood test or whatever it is, they're scheduling on the spot. I go to my doctor, they give me a ticket. How do they know I'm going to get it done? You can't get away. What they do is proactive. It's so proactive. It is so different. That's what direct primary care is. They can spend time with you. They can spend 30 minutes initially to an hour. And we can tell you story after story. I'll tell one quick story. All right, one quick story. So we had a member at the hospital who was on an opioid for about 15 years. And it's an opioid where I feel that I probably shouldn't be having this conversation with Mike in my hand. But for 15 years, Dr. Gross and his team sat down with that person, that employee, and worked with them and said, we need your spouse to come in, and we need to have a come to Jesus meeting here. They came together, they did it, got rid of the pain doctor, and the person's free of opioids. You can't get that in the traditional insurance-built model today. You just can't. My father was a 40-year OBGYN. I can tell you story after story after story. The way the model broke down in the late 80s, early 90s when healthcare and insurance merged. Doesn't work. So that's what direct primary care is. But the employer-built healthcare works, folks. We've got other examples. Cynthia Fisher, an organization, patient rights advocate, that shot those videos. They heard about what we were doing, and they reached out to us. It's absolutely possible, and there's 3 or 4 of our other clients that have also featured on that website that they came to hear. These stories exist. I can go on and on. I'm so fired up, and I told David I needed a live mic because I like to wave my hands around, but they can't hear me. So we're so passionate about this because we can fix it. But what it's got to do, in my opinion, is you got to boil the rivers, the creeks, the rivers, the lakes, the ocean. We tried to boil the ocean, and that didn't work out well, so we got a Schuessler stick now. It's a metal rod with a mirror attached to the bottom of it that we use before we crank our car. But I think you're going to do an award like that, right? But anyway, that's what has to happen. So DeSoto had the courage, and now they've got this great program that we're trying to offer out to the community, the city, the county, and the school, and the other employers, and bring them together. Relocalizing care. This hospital had, 157 employees. They had people at that hospital who've never been in that hospital for care. They were having 79% of their entire health plan spend go to other hospitals because they're a 49-bed hospital. They don't do everything, but they're a 4-star CMS hospital. They're an excellent hospital. There's not anything close to that within an hour, hour and a half. They lost obstetrics in February of 18. Now the whole town has to drive an hour to have a kid. Your state right here, where we sit today, Texas has had 21 rural hospital closures since 2013, and you got 72 of your 254 counties that don't have hospitals. That's a problem, and it can be fixed. And we built their plan and helped them, with their help, built it to encourage people to come. We broke the barriers to care. We broke deductibles and copays. We have people in that hospital, employees, now went to that hospital the first time in 20 years. It cost them nothing. You heard Hannah tell the story. $40,000 surgery for zero. So that's what we have to do, and you have to actively manage your plan. And we have partners. We have a fair cost health plan that helps DeSoto. We built that works behind the scenes with about 16 solutions that can directly impact the care of the employees. Improve clinical outcomes while improving financial outcomes. But we actively manage it. When you work with a BUCA, you are a passive manager of your health plan. They don't care. I'm sorry, they don't care if the population gets better.
Jamie, tell us about what Sedera has done, what Sedera does, and then some of the success stories that you've seen for the markets that you serve.
David, let me first say thank you for having me and allowing us to tell what we're doing at Sedera. Thanks to Texas Public Policy Foundation, and it's great to be with you, Senator, and Carl. And let me first thank you all for being in this room, because you've taken on this really big challenge in a way of saying, hey, look, this is probably the #1 issue in the country that we're facing. I don't know about you, but I'm tired of hearing about healthcare being a problem when I turn on whatever news channel you like to listen to. It's about time that we fixed it. And as Carl said, Carl has found some ways to fix it for larger employers. And I know the approach that he takes, and it works. And that's the good news. There's all this investment that's happening in healthcare right now, whether it's in pharmaceuticals or it's in the wearable devices that we wear on our wrist. But there's not a lot of innovation happening around how you pay for healthcare, right? And so what Sedera sits in is this intersection of health, and I want to use my arms too, Carl. It's kind of, it'd be nice, yeah, maybe so. Sedera sits at this inflection point, or this crossing point of health and wealth, or health and finance. And so what we help people do is to provide a different approach to healthcare. Now, I love the way David describes the difference between healthcare and health insurance. Everyone needs access to healthcare. Everyone does. But health insurance is only one way to pay for it. I think that's so fundamentally important. Carl, you were just talking about direct primary care. Love direct primary care. Subscription-based medicine, no middlemen involved. And the directness, the free market approach to that, I call it, what they do is, I don't know their particular practice, I'm sure I would like it, is advanced primary care. My doctor is far more involved in my health care at $65 a month. I think I pay almost the exact same amount. And it's an amazing experience. That's just one, we'll talk more about that, I'm sure, later. But the reason I bring up direct primary care or expert second opinion services or virtual primary care, or telemedicine. There are all these solutions that are being developed that have no insurance in them whatsoever. It's about giving people access to health care that they need. Again, it doesn't need to include insurance. So what is Sedera? Sedera is a medical cost-sharing community. It's a community of people who have chosen to come together to share each other's medical bills. And let me be really, really clear on this point too. There is not a drop or a % of insurance in this at all. There is no transfer of risk. There's no policy. It's a voluntary community of people who have come together to share each other's medical bills. And that's what Sedera Inc. does, is we just organize the sharing amongst members. Let me give you a simple example. I'm going to pick on Jenny, who's a member of our team in the office. Let's say Jenny had a medical need, and the four of us were the four that were chosen to share in her medical need that came up. It's direct member sharing. So Jamie here, that's me, I'm going to contribute my funds to Jenny. The senator would, Carl would, David would. And it's member-to-member sharing. It's a community of people supporting a fellow member in need. And what Sedera does is through innovation and technology and is we automate that and we organize that in a way that can happen at scale. Sedera was voted as, won the award for the fastest growing company in Central Texas by the Austin Business Journal 2-3 months ago. The fastest growing company in Central Texas. That's hard to do in an innovative place like Austin. Our team is really, really proud of that. But you don't have that level of success if you're not part of an industry that has fundamental problems and big problems. And so what Sedera's been able to do for small to medium-sized businesses that can't take advantage of some of the self-funded innovations that Carl and his team do, that are really, really innovative, and individuals don't have access to that as well. And so what we have is this medical cost-sharing community that small businesses and individuals can join to share each other's medical bills, and it's incredibly effective. And so what success stories, David, to go to your question specifically, and sorry I'm rambling on a little bit, success stories, let me start personally. So yes, my wife and I and our 3 boys, we have an 8-year-old, a 6-year-old, and a 3-year-old. Sorry, the 3-year-old turned 4 today. Happy birthday, Grant, I don't think he's watching. Hopefully he's at school. But they're all part of the sharing community. And so our first year, and we were on a very good buca. It was expensive. We paid $1,800 a month for our family plan, and this was going back several years ago. The first year we joined Sedera Medical, the community, we saved over $15,000. I think it was closer to $17,000 in year 1 with our membership. That's a lot of savings. Typically, people are saving 50 to 60% on their healthcare costs. But again, there's no insurance in it. But every eligible need is fully being shared and resolved. So when we had things that came up, we went to the community, we got a check from the community, and then we paid our providers. So part of the solution, and I'm sure we'll talk about this, is empowering people we have to be part of the solution in this room. The card is sometimes a problem because we say a third party is going to take care of this for us. That, ladies and gentlemen, I think is one of the biggest problems. When we go to any other element of our society, when we go to the grocery store and we're shopping, we go through the aisles. Hey, I need soap. Here's a pink soap and a blue soap. Let me read the labels. Let me smell it. Let me look at the price. How many ounces? And you make a buying decision. People think they can't make a buying decision in non-emergent healthcare. Emergencies, go where you need to go. We're not talking about that. Emergencies are pretty much outliers. But for non-emergent healthcare, we, as Sedera, we're empowering our members to be smart shoppers of healthcare. And we incentivize them with carrots, not sticks, to become those really good buyers of healthcare. So and we can talk about more examples, but let me hit on a few. We've got, and sharing, a medical cost sharing community works for big and small things. So whether it's the colonoscopy, that yes, you should need to get that done. This is TMI, got mine done, it's not bad, you won't have an issue. I know, it's the prep is the worst part, absolutely. Whether it's that colonoscopy or whether it's the unfortunate members of our community that are dealing with cancer over several years and they've gone through stem cell transplants or the heart attacks, it's the stuff at night you don't like to think about, but in the back of your mind you're worried about. The sharing community is dealing with that too, and we deal with it every single day. And so I guess what I'm saying to you is, I want to turn it over to you, Senator, but as a community, we need more options in healthcare, not less. We need more things for people to choose from. Look at what happened in transportation. For a while, it was taxi cabs, mass transit, and car ownership. Now we have Bird, we have Lyft scooters, we've got Car2Go, we've got Uber and Lyft. The current options are still there, but there are more options for people to choose from for what they need. We as a society, in our opinion, thinks we need more options for healthcare, not less. And the sharing economy is pointing to a way in which that works. And this concept that Sedera uses, medical cost sharing, yes, it's very similar to the sharing economy that we're all excited about, but it's actually being done in communities since the 1980s, and there's 1.5 million people doing it today, and in most cases doing it really, really well. So maybe I'll stop there. I hope that was okay.
And a large part of that is in Texas. Texans have really gravitated to this model as well.
Absolutely. Texas is, for us, we're headquartered here in Austin. It is our #1 state. Texas has a strong and growing population of people who've chosen not to join a BUCA plan, for example, and to join a medical cost sharing community. And I think it's working. And they're typically saving 50 to 60%.
And for those of you that didn't hear what BUCA stands for, it's Blue Cross, United, Cigna, Aetna, Humana. It's a quicker way to talk about the Big Five. Senator Kolkhorst, what are your thoughts on what we're talking about?
Well, thank you. Is this working? Yes, ma'am. Okay, thank you for letting me go last, because I can sit here and marvel at these great, innovative ideas. I have one quick question for you. That catastrophic event, do y'all have reinsurance, or what do you do?
So it's a great question. So we actually...
I'm asking y'all's questions for you, okay?
So we're dealing with those, that's what people are concerned about. It's a great question. We're dealing with those cancer situations that go on for years, the gunshot wound, accidentally, a bullet in the brain that they're dealing with this for multiple months, the 3-month NICU stays for a child that was born with something unfortunate. Those are some of the really heavy, high-priced items. We're dealing with that in a sharing community today, and it's just member-to-member sharing, and there's no stop loss at all. We are actually, based on current regulations, prohibited from getting stop loss, even if we wanted it, because of government regulation.
Well, that's a great segue, government regulation. I think that's where I come in as a lawmaker. And just a bit of kind of like we've been sharing stories. I was named chair of Public Health in the Texas House of Representatives in 2009. I was a very unlikely candidate for that particular position, given that I had spent the 6 years prior on House Appropriations Committee. I was chiseled out of stone by one Talmadge Heflin when we started with zeros in the budget in 2003 and actually built a budget off of zero-based budgeting. But the unlikely candidate is that I'd never filed a bill at that point that had ever gone to public health. And now I'm the chairman. So no interim, nothing to get kind of up to date. Here I am, right? So here's kind of my story. I'm an athlete, love athletics. And I went in that and I said, we're looking at all these, Obama had been elected. We're swimming in red ink in our federal budget. The Affordable Care Act had been passed so that everybody could finally read the bill, right? And I'm sitting there and I go, okay, I'm going to solve this. That's what I do. I'm an athlete. I'm going to solve this. And it was kind of like, guys, I was going to save America because we're spending too much on healthcare, and this is what is crowding out every other priority, education, other things that we care about deeply as well. And it's just the one part of the budget that just is growing at an exponential rate. It was like I took off on a 100-meter dash, and I was running, and all of a sudden, it wasn't even an opaque shield. It was like this plexiglass shield, and I went, wham! It's kind of like that bird that flies into the window, and then you just slide down the window. And here's what I learned, that many in healthcare don't want us to lower the cost of healthcare, right. It's a business model. We have, now Senator Kolkhorst, but back then, Chair Kolkhorst, we have debt that we have to pay. The model is off of, that this is going to grow and grow and grow and grow and grow. So that's kind of my story of the struggles. When we're talking about bending the curve, at the time was a real famous thing to say, and everyone knew that we couldn't keep growing at medical inflation numbers. So I think what we're talking about here today is innovation. And I think James said I can't do that because of government regulations. I think that's one of the biggest problems in healthcare is the third-party payer, whether that's in Medicaid, Medicare, or in private insurance. I had a doctor once tell me that his daughter needed an MRI, and he did not call around. He was on a health savings account, didn't call around, just sent her down to the local hospital, and she got an MRI for like $3,500 or $4,000. Because it came out of his health savings account, he was curious. He started calling around, and if she would have just driven to the county next to us, she would have gotten it for $800. And that was a doctor that had not shopped around. So recently, I don't know if y'all saw that Reuters came out with a pretty alarming story that mentioned that U.S. insurance companies and healthcare providers spent more than $800 million in 2017 on administration, which totaled about $2,500 per person in our country. And so when you look at these ideas that we're talking about, it's innovative, and that's what we need to do. I sit here as a person on the budget. I did Article 2, and I also do now chair Health and Human Services. And we're looking at a number of things that can come down the road. I spend a tremendous amount of time looking at Medicaid because it's such a driver in our budget. We got some good news yesterday that one of our waivers was approved. We've waited for years for the Healthy Texas Women waiver to be approved. I see one of our state representatives in the back. Yay, cheer. Long before you got to the House, we were trying to do this. And that's just one example of what I think we could see from this current administration. Healthy Texas Women is this. We realized that maybe some of the providers of women's health care were actually also abortion providers. And we said in Texas, we don't want to do that. And so we cut out some of those providers. At the time, the Obama administration, CMS said, fine, we're just not going to give you the money. That was the federal match. We have waited years and years and years, kept putting up that 1115 waiver, and just yesterday it was approved. Now, some on the left say this is a disaster. It really isn't. Actually, we're going to get $350 million over the next 5 years to improve women's health care. It's a very positive thing. We were doing it out of general revenue anyway, so it frees up some dollars, and it allows us to be innovative. And when you say government and innovation, it just doesn't work very well. And so it's through these waivers that we waive off federal regulations. We have a number of those up there right now. I know my longtime staffer, Brian Law, and I have, since my days in the House, been trying to innovate in the Medicaid arena. And part of that would be consumer-driven. Just because you have lesser means and that you might fall in one of those Medicaid groups does not mean that you're stupid. Does not mean that you cannot be in control of your health care. And I've long advocated for block grants in Medicaid where we can empower the individual, just like these two panelists have talked about, in making decisions on your health care. You can do that in a number of ways, but right now Medicaid is a one-size-fits-all Cadillac of all insurance. That none of you, I don't know what health care y'all have out there. Like you say, health care, is that insurance? That's what we think of it today, and it isn't. And so we had a pretty interesting conversation on my staff this week about, access versus coverage. And those that are maybe to the left of me talk a lot about just coverage, but that doesn't equal access. And there's a number of innovative ways, even that government, through FQHCs, have done some things where there's a sliding scale. You can go and get your primary care there. They assess your needs. You pay on your ability to pay, but you are more in control. I love your soap analogy of soap. Sometimes I talk about the purchase of a car. None of us, let me say this. If you didn't have to pay a dime for a car, which car would you get? Well, I love BMWs, okay? Now I'm an elected official, and so I drive an American-made car. I know we have BMW factories in different parts of America, okay? But Chevrolet is what I drive. But I got to tell you, man, if somebody else was paying for my Chevrolet, I might get that fancy Cadillac Tahoe, right? Instead of just my Chevrolet, because somebody else was purchasing it. So when you have that third-party payer, you almost forget about quality and price. And that's why we've got to get it back to first payer. We have really got to become that way. And I mean that too in our Medicaid and our government programs. It is extremely important. So in the next session, I think you'll see, you heard that on the panel with Governor Patrick today and Senator DeMint with the think tanks that he's involved in. We probably have 2 to 4 years to really push the envelope. We're waiting for CMS to come out with new rules on block grants concerning Medicaid. Right now, there's a rule out there that has to do with supplemental payments and how we cover the uninsured in the state of Texas. And it's really got a lot of people nervous because it could change and maybe be too much of a disruptor for our state. But if we could, in the next session, look at this in a patient-centered, maybe even introduce the concepts of direct primary care into even government-run programs, and innovate in that kind of way, I think those disruptors will create a new health system moving forward. Now, to all of our health providers out in the audience, we don't do very well with that. When we have big systems, big hospital systems, they get nervous about when we say, hey, we're going to really bend the curve. We're not going to spend as much money on healthcare. Because again, it was like that wall that I ran into, like that bird flying into the window. I didn't understand that everybody didn't want us to be successful in that regard. So I think that's the challenge for a lawmaker, is balancing the current system that we have and not see it crater, but yet move toward them remaking themselves. So the taxi cab, I was just in New York City. Oh, thank you God that I don't live there. Okay, nothing against people in New York, but it's just
Amen.
not me. Now Lois Kate, she wants to go to New York and work there, break a leg, okay? But not me. But you do know the whole time I was in New York, I did not take a yellow cab. I Ubered everywhere we went. It was really, my staff is pleased to hear about that because then they don't have to come get me. Just Uber, boss, right? But how much that has changed. I mean, how much that has changed that. And those are the disruptors that we're seeing with their two models and where we need to move forward. And those numbers need to get big enough that it does really disrupt the system. I think the role that government plays is, again, not watching some big systems crater in our hospital networks and some of those providers, but allowing them to reinvent themselves. One last plug for rural Texas. This has not been a good time for rural Texas. The Affordable Care Act did a great deal of damage to rural Texas. And you might say, why? How? It was the cuts in Medicare that rural hospitals depended on greatly. This last session, my colleagues in the Senate, we put together a really nice package. The House agreed with us where we're pushing a little bit more money out there to make sure that we have a safety net system. I'm going to brag on the Baylor Scott and White. in Brenham, when I went to last session, they were just going to stop doing deliveries. Now, let me tell you, if Brenham can't do deliveries, we're done for in rural Texas. And it had to do with recruiting an OBGYN. They didn't want to use a family practice doctor, which by our rules, you can, but that's their standards. And they have aggressively now recruited two new OBGYNs. We are incentivizing more deliveries in rural Texas because, as you say, driving an hour, at least an hour to deliver a baby is not always safe, especially on those well babies. And I'm really proud of Baylor Scott and White in Brenham. In fact, they just got voted by the consumers as the #1 hospital in that system for patient satisfaction. That's a small rural hospital, really, meeting the needs of the people around them, and I'm very proud of that. But we have to be careful about what we do in government. Especially on the federal level, but if like Senator DeMint talked about, the states are where we can innovate. And go back and study Ronald Reagan in the 1980s, and he absolutely believed that. He looked at the Medicaid numbers and said, man, we cannot afford this. Give it to the states, they'll figure it out. We just haven't gotten there, so hopefully, 50 years later, we can get there.
Let me jump in on one point. I love your car analogy, Senator. What's the crazy part about healthcare is you mentioned the BMW and the more let's call it the coupe, right? I don't want to name say that car is not a good brand or whatever, but you've got
Chevrolet's great. I love Chevrolet. I drive.
Okay, so you're Chevrolet, which is a great car, and then most people we consider a BMW a fancier car, right? For some reason, in healthcare, the BMW is cheaper. The BMW is cheaper. Do you know why? Because when you look at LASIX, if you look at the price trend of LASIX over the last 20 years, it's not paid for insurance. The cost of LASIX has been stable or gone down. It's really gone down. The most efficient places that get procedures done, they get really, really good at it, and they're taking care of people's hernia. There's an efficiency that's developed. Complications go away. Complications cost money. So if you ask the Texas Free Market Surgery Center, Sean Kelly, great organization in town. They are, their price transparency is a big thing for them. They're modeled after, you may have heard at the Surgery Center of Oklahoma and Dr. Keith Smith. All of the prices for all these procedures are on their website. How can they do that? Well, ladies and gentlemen, you can. And so these places that really get good at it, their prices go down and the complications are low, the outcomes are better, and that's what we all want. So it's like healthcare the cost of healthcare and the quality of healthcare is in many cases inverted. The more costly it is, chances are the outcome's not going to work out as well. So, sorry, just wanted to make that point.
And the data supports that. The higher cost providers and facilities are typically the lowest quality.
And I have to add something to this. So it was kind of back, in those House days when I was chairing public health for the first time. Again, my zeal and my zest for solving this problem. I talked to a physician, and I was asking that very question. I go, now listen, I don't get this, like you have this master list at the hospital, but it's really not the real price, and then the insurance companies kind of use that as a marker, and then they discounted this and that and the other. And I said, now I'm really kind of like, what if I just wanted to pay cash? And this doctor looked at me and he goes, now listen, I've been in hospital administration for, a long time. And he goes, it's a very opaque system, and we like it that way. Wow. I was like, man, I think I've been named the chair of the wrong committee. I do think that the Lord called me there, but that was the answer that I got. Now, I know doctors. I came from a medical family, and what they really want to do is serve patients. they're never good at paperwork and all that stuff. They want to make a decent living. They've put a goodly portion of their life into studying. They go in to serve people. And so, like the physician-directed, doctor-directed, the contract that you have, $65 a month or whatever, they've got to love that. I mean, do they have good?
Sure, they do, and I think you hit on a couple of things. And we talked about it yesterday. I think everybody knows this, but where else in America would you go and buy something and not know the cost of it and find out 30 days later? I mean, and I know everybody, I don't know if you sit around and up at night like I do thinking about stuff like that, but it's crazy. Yeah, and when I told my father, who, like I said, delivered babies for 40 years, that we had worked out for DeSoto Memorial some cash prices for deliveries, and I will not name the hospital, but this particular hospital charges $37,000 for a vaginal birth. My dad about fell out of his chair. Okay, we were able to negotiate a cash price for $7,500 and give that employee back 50% of the savings, up to $2,000, to offset any costs. Most of the time, we don't have any costs because we don't have any deductibles for parts of our program. So, I think you hit the nail on the head, and I think on the back of that handout y'all have in your chair, it defines neighborhood health care. We've got to get back to neighbors helping neighbors. Back when there were no middle people, there were no insurance companies. That's what's missing. Everybody laughs when I say this, and I can't tell. Looks like the room probably will know this. I'd say take it back to the Marcus Welby MD days. And if you don't know who that is, you better Google it.
I'm old enough to know.
I am too, unfortunately. So the point is, that's what you have to do, is break the barriers to care down. You talk to these doctors. The local care team needs to be the direct primary care doctor, the primary care, the specialist. The pharmacist is a big role, and those community pharmacies are going away quickly. And the patient. We need to have a patient-centric system, and what we helped DeSoto build with the Fair Cost Health Plan was a patient-centric system, and they are able to find the price out for things except the emergency room before they go, Senator Kolkhorst. We've got a program where they're able and they're required to call.
Okay, so you brought up pharmacists. This is really important, David. Okay, so how many of you know your pharmacist? I know my pharmacist. He lives up the road from me. And I've got to tell you that Atwood, he saves me a lot of, time. He's a wonderful caregiver in ways, okay? But now I'm going to really go from messing to meddling, so my chief of staff's about to melt into his chair, but I'm about to say it. Pharmacy benefit managers, PBMs. They started out, they were supposed to be only 1 to 2% of the spend. They're now 17% of the spend.
It's program bilking millions, not pharmacy benefit managers.
Okay, all right. So, and I've got to tell y'all, so I'm sitting in either it was a finance or hack committee, and I asked the question. I said, "Well, on these rebates and all these formula stuff, how much of a rebate do we get? Like, what percentage?" And they go, "Oh, that's proprietary." And I was like, "This was a state agency run PBM, and so they had contract." And I go, "Well, what do you mean?" And they go, "Well, we can't know that." And I said, "So we don't know if we're getting a good deal or not. If the pharmaceutical is giving a rebate of 50%, and we're only getting 5% of it, and the PBM's keeping 45%, but we don't know that. Maybe we're getting 45% and the PBM's only, but who would cut that deal? I think that's been the whole point. Who would do that?
No American business.
No, not one. But we have American business, to your point, that are buying insurance. And all of this is going on that never gets to the consumer. That service doesn't get to the consumer. It's driving healthcare costs. And I can speak to any teachers out there. We as a state only cover $225. I'm roughly right on that. And then local districts might kick in a little bit more. And then our teachers who are teaching our children have to cover the extra part of it, or their family. And it is one of the largest cost drivers in their budget. It rivals their mortgage payment. That shouldn't be that way. It just shouldn't be that way. So I'm glad to be a part of this panel. David has given me, I think it's only 500 pages that I'm reading from you that you sent me recently.
I'm just getting started.
Well, my staff did a nice job of printing it out, but I also then downloaded it to iBooks so that I can read it. There's a lot going on out there, And we, being at TPPF, we're lovers of the free market. The biggest industry that I know of that is not free market is healthcare.
Well, you make a great point about free market. These solutions don't have to be don't have to be complex, right? So what you did, Carl, with the hospital in Florida, it's not like their member experiences, they had to learn all this stuff. We can create simple solutions that break down the barriers that are between the doctor and the patient. You know, the relationship between the doctor and the patient, I would say it's sacred. And we put too many, people between them. And so let's bring the patient and the doctor back together, lower some of that admin cost, right, that's happened in between there. And, your comment about the Marcus Welby, MD, that's what I would say direct primary care is. That's that kind of relationship with your doctor. Primary care has been a problem in this country. Not enough people go see their primary care doctor anymore, and we need to reverse that. Last comment on pharmacy, and I see David standing up to, I think, launch a Q&A,
Go ahead.
is many times, there's a report that came out in the last week or two, that many times people with an insurance plan, it's cheaper for them to say I'm a cash pay patient when going to get their pharmacy, to go get their drugs filled, right? And that is, that's a challenge. The fact that the insurance they're relying on, it's actually cheaper for them to not use it, doesn't make sense.
But if they present the insurance card, as we know from Vince, the CEO of the DeSoto, if you present the insurance card, they can't give you cash price. Part of the contract they sign, part of that proprietary stuff that you can't see. The scary part, Senator Kolkhorst, is these businesses have signed stuff that they can't even read nor understand, that they would never sign a lease for an office building without being able to read it. But guys, I can tell you, and I can get long-winded, but I'll be real quick. You want to know how to fix this? You eliminate the middles. That's what DeSoto did. There's no insurance company involvement whatsoever. Period. They became their own PBM. There is nobody. There is no middle people. And we've improved the care tenfold for them. And I think this is one other thing all y'all need to really think hard about. And if I were you, I think to sit in front of the legislature and say this: how many employers in America, if their employees were polled, would vote for single payer right now? I guarantee it's a lot. You go to our clients, 75% would say, no way, we got the best insurance in the world, and we're not paying much for it. That's the question that needs to be directed out there.
In a Sedera context with medical cost sharing, we're not incentivized to not share a bill. We're actually incentivized to help our members save money. There are insurance companies, they make their financials are tied in with whether they pay a bill or not, or pay a claim. Sedera makes a set number of dollars per member, regardless of whether we share that bill or not. And so the focus is on the member and the member experience and taking care of the members. And I think that's what we're talking about here, and getting back to that type of direct relationship and getting rid of some of those middle barriers.
Do you have one more thing?
Yeah, we're in talks with major health systems across the country that are wanting to do direct contracts with our clients. And I want to get one other thing, level set real quick on these terms, and it drives me batty when I hear them. When you say the term payer, and I agree Medicare and Medicaid are payers, let's be clear, folks. Who are the payers? Anybody know who the payers are? Yeah, employers and employees. Get that out of here. Those folks, as my friend Barry Murphy says, are processors. They're processing claims with your money. Number two, reimbursement. Again, father practiced 40 years. I'm getting reimbursed for delivering a baby? No, I'm getting paid for what I did. Those are payments, they're not reimbursements. That needs to go away. And then the last one is providers. That's so confusing. Facilities, physicians. Providers is such a vague term. Let's go. Y'all ready to suit up?
I'll hang
Let's
out
go.
with these guys anytime.
I'm going to have to apologize for how shy the panel is today.
It's a problem.
Thank you all very much. This has been fantastic. I want to take a little survey, if that's okay. Before coming to policy orientation, who here has heard about direct primary care or DPC? Maybe about half, a little over half. Who here has heard of a PBM or a pharmacy benefit manager? That's more than I expected. Well, I didn't say it was a good way. Just in general. I hope today was of value to you. We're going to continue to build this vision for healthcare in Texas and across the country, but we certainly need you to be a part of that process. We're going to open it up to Q&A. We want you to be involved. I know there are going to be a lot of questions. Please make sure that it is a question and direct who you want to have the question go towards, and we'll just go ahead and I'll let you choose.
Thank you. Can you hear me? My question goes out to Mr. Lagarde. Is that how you pronounce it?
You're doing better than most, Lagarde.
Okay. All right, I got my master's in healthcare administration, and one of the things was in one of our courses what's called a PPPM, where you divide the cost of healthcare across everything. I like what Senator Kolkhorst said. Okay, throw out the catastrophic deal. All right, but you never answer the question about the obesity, diabetic, the hypertensive, the smoker, the people that do not take care of themselves. They should be penalized. You didn't even mention about penalties. So that's the other thing. And the second thing I want to talk to is kind of throw it out there to you. We're physicians, and so I have yet to ever hear anything about discussions about we're up at 2 o'clock at night, the patient comes in, has no insurance, has gunshot wound, and we take care of them, and the hospital gets reimbursed for an emergency, okay? We don't get anything. And yet, in the kindness side of the patient's heart, they might even sue us. So what are your comments about that?
Okay, first part of the question, let's tackle that one. Penalties. So the way Sedera, think of Sedera as we're an option that's out there that we hope works for a lot of people, and we've got now, 25,000 people throughout the country, not in every state, but in a lot of states that are taking advantage of being a member in the community. Part of our community, and there are different communities that are out there, we focus on a healthy lifestyle. One of our things that we're trying to accomplish is to reward people for caring about their health. So for example, someone can join who's a tobacco user, but you're paying a little extra for that, right? So healthy lifestyle is important, and we want we may be doing other things around those lines as time goes on, but we want to reward good behavior. We want to reward people who are being good shoppers for healthcare. There's a portion that the member pays, and there's a portion the community pays when it gets to be a big bill, right? The community steps in and helps and direct shares. But if we've got a good community member who's shopping around, if the MRI, for example, there are places where we see MRI charges that are $4,000, where literally across the street, you could have gotten that MRI from the same machine, same radiologist for $400. So if we've got a member who's making smart buying decisions and doing that type of research, they're not paying anything out of pocket. The community's like, you did such a great job. You saved the community so much money. Your entire healthcare bill for this is paid. And so we've got to do more of things like that. We're proud of the innovations that we've done. We're just one company that's a good option, but we need more options. Direct primary care is another example. Your second part of your question might be better for the senator. I would say that I saw something that came across my Twitter feed that said physicians only get 7.3% of the healthcare dollars. That's terrible. There was this big red box of all the administrative fees associated with it. We've got to do better there. The physicians are driving the ship for healthcare, and again, we need to remove the barriers between the patient and the physician. I hope that answers your question. Senator,
can I say something real quick about the diabetics, or you mentioned the obesity? One of the things the DeSoto did is anybody Seinfeld fans? Yes. No, okay, all right, well, very quick. Do you remember the episode when George was sitting with Jerry at the cafe, and he said, everything I've done in life that my intuition told me to do, nothing ever worked out, so I'm going to do the opposite. Remember that? And
Oh, yeah.
there was a pretty lady sitting at the table, and he goes, I'm not going to talk to her. Okay, I will. My name is George. I'm unemployed, and I live at home with my parents. And she said, have a seat. You got to do the opposite. So I'm done. It's that simple. What I mean by that is, I'll make the real quick point. When you have a diabetic, we know that 10% of almost every population is diabetics. When you require them to buy their test strips and their drugs and everything else they have to have, most Americans don't have any money and can't afford to do it. So DeSoto did the opposite. They provide glucometers to their diabetics, and they will have to have it checked 2 to 3 times a day. And the partner that we brought to the program calls these employees. If they don't get the glucometer done, they're calling them like you've never seen. You think debt collectors are bad? They're all over them. Hey, why hadn't you done it? Are you okay? It actually saved one employee's life. Not that particular, another device, but those that do the opposite. If you keep the diabetic in a good position and adhering to meds, they don't end up in the ER and they don't end up in the hospital. That's doing the opposite. And that's what, oh no, we got to have a copay for that. It doesn't work.
Quick answer. So we do uncompensated care through payments from the federal government, and it's a really complicated formula that is now, there's a new rule that's been published. So the hospital does get reimbursed, and depending on your arrangement with them, that's something you and I can talk offline. But uncompensated care is covered in a formulaic way that we disperse money through different waivers here that we receive from the federal government.
And if I could just say this real quickly, in the vein of doing the opposite, I've been counseling my colleagues with Texas Public Policy. Ask the cash price. Ask the cash price. And I got a message today from one who, for a lab test, with insurance, $1,600. The cash price, $249. It would have been out of her pocket either way because she hadn't hit the deductible.
David, this is actually from my friend Carl. In light of what you just pointed
Are we
out.
friends?
You're
Okay,
one of my
okay.
friends, yes.
You've got it on record.
I admit that rarely. But Carl, explain to the audience, if you would, the fundamental driver under the ACA in terms of how the ACA incentivizes insurance companies under the MLR to not contain costs.
Could you repeat the question? I didn't hear you either.
Carl, I was going to ask Carl to explain to the audience, under the ACA, okay, the Affordable Care Act, the medical loss ratio and how that is driving all of this insanity in terms of how it incentivizes people to continue to spend.
Okay. Go ahead.
Okay. We might let David do that. What it did, it's a great question, is the ACA at first, I mean, it did some good things. It did. I think it also did a lot of bad things as well, but it did do some good things. What it basically said is the medical loss ratio in the large groups was 85%, meaning, guys, that they had to pay out 85% of all the premium dollars they collected out in claims. I think the smaller groups were 80%, so they had to pay out 80%. When their margins, they got to keep that 15% or 20%, how were they able to do better, and how could they make more money? So the more the prices went up at the hospitals and the charge master prices went up, the insurance companies made more money because that 15 or that 20%. So it did incentivize anybody to bring the cost down, and that's what I was saying earlier. They don't want the cost to go down. That's how they make more money. Did I answer it well?
Absolutely.
Balat probably could have done a lot
And
better than me.
if you look at the publicly traded stocks, United, Cigna, you'll look at how they far outpace the S&P. I mean,
No question. I mean, some of them are 1,500%. We put that slide all the time on LinkedIn. If y'all follow us, it's out there all the time. And
If you're capped at-
bankrupted middle-class America.
If you're capped at 15%, the only way to make that 15% go up for your shareholders is a bigger number, meaning premiums go up for everybody.
I like to say it that, ba-bump, ba-bump. And that's the rest of the story.
Okay, hi. I just have a couple of questions, and it's a two-pronged question. The first question is probably for Mr. Lagarde and also for Senator Lois. And the second question is about payments. So first of all, what, if any, is the patient appeals process? Or are there guidelines or any government patient advocacy groups for procedures or care that gets denied coverage? And do you have a list of currently denied procedures, charges for drugs and so forth? And does the patient have any government recourse or channels to appeal or fight for coverage or reimbursements? So that's my first question. The second question, and sorry if this is long, it sounded like paying cash for a delivery. That's kind of high, and that's cash. Are there any payment plans? Can they charge it? And do you know when what to do when they don't have any cash because they've already spent it on their monthly health care coverage? So, and are these fees included in your cost reductions that you're talking about of the 30-40%?
Well, I'll start. The way we talk about a delivery for with Sedera, we have a lot of new babies coming into the world, and we can talk about this more offline about the mechanics about how the sharing process works. But essentially, we would look at that as an incident or a need. This member has a need; they're having a child, and they have what's called an initial unshareable amount, which for a lot of our members that take the membership, it's $500. It's a lot less expensive than a $5,000 or $7,000 deductible. So members are having children, the whole cost, including the prenatal care, all the way post to delivery, for $500, and the rest is then fully shared with the community. Period, end of sentence. So we get a lot of people who like to join the community to take advantage of that. There is one document which describes how our sharing community works, and it's on our website. And so again, getting into options. Do I think Sedera works for everyone? No, there's other sharing communities that John Smith may think that one's more appealing than ours. Of course, I'm biased. I love the sharing community that we run. But the guidelines are right there on the front page of the website, or second page, and you can see how the community operates. And if it works for you, great. We'd love to have you and talk to you about being part of the community. As far as appeals process, I'll mention that. There is an appeals process that works, and it starts with Sedera. But if you're not satisfied with that answer, your appeal for something that's being shared, you actually go to community members, fellow community members, to decide whether or not that's going to be shared with the community. So Sedera is actually not in charge of the community on a final say for a bill. It's actually the community that's in charge. And we think that's important. If we're going to really be community focused, we're not we're not the final arbiter on that. It's the community folks that have come together to share each other's medical bills. We'll pull a few of them together to look at the case, and then they decide what to do. So,
Is that your board of directors, or do you have a board of directors?
we have a board of directors, yes, but the decision on whether something's shareable or not, are randomly picked members who've been with the community over a year. So it's truly community members, not people who are on a board.
I'll answer the appeal process for Medicaid, now that we have MCOs that run the vast majority of our Medicaid programs. That is an appeal process that goes through the managed care organizations, and it's difficult. So this last session, we passed a bill that gave more of a voice to the patients, especially the MDCP program, medically dependent children's program, that had segued in from fee-for-service to MCO and had lots of pushback on that. So we've given a more robust appeals process. We as lawmakers, I have truly weighed into some of those. When a constituent calls me, we look at the case and we say, we really think that this service was denied and it shouldn't have been denied. And so we sometimes get involved as well. So, but statutorily, we improved what I felt like was a really rough appeal process.
Do I need to, did she ask the cash price? Was that for me? Were you wanting to ask about the cash price, or was that at the end, your second question?
Okay. Next question.
Hi. So my question is, what do you consider, or how do you make the determination of what's elective or covered, for example? So like drug and alcohol treatment. Someone needs drug and alcohol treatment, or say someone's got fertility issues. Like, are those things still covered in that, or would they be up to an individual to cover for themselves?
Is this a question for me? Oh, for both of you. Well, you want to start, Carl? Okay. Oh, okay. It goes back to this guidelines. If you have something that's going in, and again, you should, someone who joins, when you sign the membership paper, it says you've read the guidelines and you know how the sharing community works. And so, people come to us with big and small stuff all the time. Again, we've got people with the cancers and the stuff people worry about, the NICU stays, and I'll just say, we've got a child with ADHD, and so the sharing community is helping us with that. It's just an example, just talking about a personal example. And so the sharing community is sharing, not covering, sharing all sorts of medical bills with each other, and it's driven by that one document, and we talked about the appeals process earlier.
We customize those plans, they're employer-built, so we can actually customize the pre-cert or prior auth list. We did it for DeSoto. DeSoto has 2 pre-cert lists. One pre-cert list is for their hospital, and I'm not allowed to say, but the former BUCA organization involved was denying claims at their own hospital, would not allow someone to have a surgery at their own hospital they worked at. That's supposed to be funny. I mean, that's crazy. That's crazy. That's crazy. And I remember Vince, the CEO, was like, "This is what?" I mean, they don't make any money on their own employees, right? They're a hospital. So they have a pre-cert for other hospitals, and they have a separate one for theirs. And you do customize that. You got to work with your stop-loss carrier and your partners to get that right, but absolutely.
Before we get to the next questioner, I want to talk about the other forms of direct care, and we have a policy perspective that we just finished that it's available on our website. If there are any left, there should be some on the table. But direct primary care is one. Direct surgery we've talked about, as in Surgery Center of Oklahoma and the Texas Free Market Surgery Center. Direct pharmacy. Getting insurance and PBMs out of the way. I was talking to a gentleman who is starting a direct pharmacy organization. Humalog, which in 1996 cost $34 a vial, is currently over $300. And with some coupons, it can get to about $150. Their price is $55. In talking to people with diabetes, that is a game changer.
Good afternoon. Good afternoon. As a former member of the board of managers for John Peter Smith, we talked a lot about end-of-life situations. And every time I go to an event like this, I ask the same question. It appears as though, from every statistic ever done, that the majority of the healthcare costs you have in your life is in the last year, or the last 6 months, or last 2 years, somewhere in there. And none of these kinds of things ever deal with that, because we have, of course, the socialized care that we have today. You wind up having a would-be widow that's keeping a man alive longer than he should be, quite often in a veterans hospital, or situations like this, where people are kept alive artificially so that somebody's benefits don't run out, or just simply because they love that person, they don't want to let them go. And this is not something about euthanasia, but it's very real cost that we are suffering and paying for because we're not willing to let somebody go when their time has passed. What are we doing about this? Or are we just all hoping that this gets better?
Can we take it? Coming from the hospitals, I can tell you that many of the folks in the hospital are prolonging those situations. Let me tell you about my direct primary care doctor. He was trained as an intensivist, one of the highest level pulmonologists, working in the intensive care with people who are in bad shape. Graduated from his residency at Yale and was in the ICU, and it was basically just keeping them well enough to stay there. Didn't even have the opportunity from his leadership to usher them into the next phase of their life. And he threw his hands up and he said, "This isn't what I went to medical school for. So to the chagrin of his parents, he said, I'm going to go into primary care, and he became a direct primary care physician. What we have today in terms of end of life, we have focused too much on what we're doing in these hospitals. I can tell you that if you want to get sick, and if you're having a regular surgery or if you're having a very routine type of surgery, avoid a big inpatient hospital because the likelihood of getting a secondary infection is very high. And those prolonged stays are typically because you're on heavy antibiotics throughout that time period, and it's just not good. And that's when people get septic, and that's all very, very expensive. And as many of you all know, if you're a patient in the hospital, if there's some doctors, if they're just looking in your room, you're getting a bill. So it's just very, very expensive to be in the hospital. Oftentimes, that level of care isn't necessary. That's why we're focusing on primary care. Now, I'm not saying primary care is the answer. I'm saying that if people start to have a relationship with their physicians and they're practicing wellness, because in this country, we don't have health care, we have sick care. Everything is reactive. So we need to have a reimbursement methodology, which direct primary care is the only one that I really know of at this point that is focused on keeping people well. And it's proactive and it's true health care. To address your question with greater detail, that would require, I think, a bigger study, but it's something that I think that we should look at, and I appreciate you asking the question. I apologize, I'm still hands up, but we've come to time. Well, we have one more minute. How long is it?
The gentleman right here has wanted to ask a question.
All right,
My question's for Carl, and I understand the DPC and that, but that seems kind of tangential. It seems at the end of the day, I'm not trying to minimize what you did, but at the end of the day, did you just get rid of taking insurance? I mean, is that really the magic formula, it seems to me? Or was I not paying attention? Or
No, that's okay. That's the challenge we're all under, to try to make this more simple. They have one of the best health plans in America. Make no mistake about it. There's no deductibles in parts of them. They're very minimal copays. We improve the benefits tenfold for 46% of the cost. So they absolutely have insurance. They have a card. They can go anywhere in America. Cleveland Clinic, Mayo Clinic, they can go wherever they want to go. May have a little bit more out of pocket, but not even closely out of pocket as many of your employers have, I promise you. So that's what we did. No, they have absolutely regular insurance. They just have their name on the card. They don't have a Buca name on the card because that's the payer. That's the payer is the employer and employee, and it has their name on their card. Does that help, or did I not?
Yeah.
I'm glad to speak later. Guys, you can fix this. Absolutely, it's possible.
And David, I want to say this. One time I was on a panel, and I was with a couple of experts, and one guy said this, and I'm going to challenge, I think you're at TPPF, you're probably a Republican or a conservative, and this is what he said. Listen, Republicans are terrible at health care because of three reasons. It's too expensive, too complicated, and too risky, and so they usually flee from it. My Democrat colleagues, they have gotten in this arena, and they've done. They love it. They do really well with it, and they've created a centralized medical system in Washington, D.C. or Baltimore at CMS. And so I challenge all of us to think about these. We're innovators and business owners and disruptors to the system, so get in it. Get involved. And don't shy away from it because it's too complicated, too risky, and too expensive. The examples today have really blown too risky, too complicated, and too expensive out of the water. Thank y'all for letting me be a part of this today.
thank y'all for coming.